And welcome to the Outcomes for Me webinar on managing breast cancer in the age of COVID-19. We have over 100 participants today joining us, and we're broadcasting live on Facebook. We're very happy you're able to join us for this Q&A with Dr. Hal Burstein. Dr. Burstein is a professor of medicine at Harvard Medical School and a breast oncologist at Dana-Farber Cancer Institute and Brigham Women's Hospital in Boston, Massachusetts. He received his MD and PhD in immunology from Harvard Medical School. My name is Maya Saeed, and I'm the co-founder and CEO of Outcomes for Me. Outcomes for Me is on a mission to empower cancer patients with personalized evidence-based information. We believe we can create transparency for patients to improve care and accelerate research via our app. Dr. Burstein and Outcomes for Me have come together today to help get the facts straight regarding managing your health as it pertains to breast cancer with the current outbreak of coronavirus. We have reached out to our users across all platforms in the last few days and have received a number of questions that we will be addressing today. I will be moderating the questions with Dr. Burstein, and feel free to submit more questions by commenting to us directly, and we will do our best to get to as many questions as we can today. Make sure to include your email address when submitting a question, just in case we're unable to get to the question during our time together. Thanks again for joining us. Our goal today is to have you leave here feeling more informed and more secure during these difficult times. So let's get started. Dr. Burstein, we received a number of questions along primarily 5 themes, and these 5 themes are, just generally as a cancer patient, am I at high risk in this pandemic? The second theme is, what is the impact of specific breast cancer treatments people are currently on, and should they discontinue or not discontinue these treatments? The third theme is around postponing treatment, and what is the impact of that on breast cancer? And the fourth theme is around postponing appointments that are not directly linked to treatment, more around screening and surveillance. And finally, the final theme is around hospital and clinical office safety in these times and guidelines around there. So I suggest we start with the first theme. And on the first theme, which is the risk of being a breast cancer patient in this context, we really had 4 kinds of questions. The 4 questions are, first is whether a breast cancer patient needs to be more concerned about coronavirus than another person, and are they generally at higher risk, including travel safety, etc. The second is whether if people have completed treatments and including radiation and surgery, how long does it take to build up the immune system, whether it's radiation or others, so once they've completed treatment. And the third is around lymph nodes and whether having removed a lot of lymph nodes impact the immune system. And then the fourth question in this bucket is around also the immune system and how compromised is it after finishing chemo. With that, let's get started. Doctor, the floor is yours.
Hi, Maya. I'm very happy to be able to join you today. And I hope that everybody who is joining us is healthy and well, and that their families are well. This is an extraordinary public health event, unique in my professional lifetime. All the major hospitals and cancer centers are literally changing day by day their standard operations, and we are having conversations with our patients along these lines of the questions you just posed on a regular basis here. So let me just say a few things. As you know, this is a viral infection that is widespread now in the community across the United States and in many, many other parts of the world. And there's no particular reason to think that breast cancer survivors or breast cancer patients are at greater risk for contracting the infection than anyone else. The infection is spread by close physical contact, by aerosolized viral particles, by contact with surfaces that those viral particles have contaminated. And so the most important thing for breast cancer patients is the same advice we are giving to the general public, which is social distancing to reduce contact and hand hygiene, hand washing using soap and water, or if available, products like alcohol-based sanitizers like Purell to keep yourself as free from exposure as possible. there is no unique thing about breast cancer history that would increase the risk of infection for our breast cancer patients or for our survivors. Having said that, there are concerns that cancer patients who do get sick might get a little sicker with the coronavirus than other individuals. It must be said that the reports here are mostly from the early experience in Wuhan, China, and in northern Italy, and that these were often older individuals, a lot of men, and that this was not unique to cancer patients. They were often lung cancer or esophageal cancer, many of them smoking-related cancers, which again is not something that's uniquely linked to breast cancer. In that experience, it seemed like cancer patients or people who had a history of cancer did not do as well if they became acutely sick with the coronavirus. So that's something we're all trying to learn about and understand. And I think common sense would suggest that people who have other health problems, who have particularly metastatic cancer, who are getting intensive therapies, might be more vulnerable to getting quite ill if they become infected. And that underscores the need that, again, the first and most important thing is this kind of social distancing, quarantine, and good hand hygiene and other personal habits to do all one reasonably can to avoid infection. There are limits to the success of those approaches. I'm sure many of the audience have noted that in the past few days, celebrities from basketball players to Tom Hanks and his wife Rita Wilson, who happens to be a breast cancer survivor, to political officials like Prince Charles and the Prime Minister of England and others have been afflicted by this. So there are limits to what one can do, but I think the first thing for breast cancer patients is to start with those. Now, in terms of specific treatments, we can talk a little more about how a past history of therapy or ongoing therapy might affect your risk. The most important thing to say here is that radiation therapy by itself should not pose any risk to patients in terms of outcomes for infection by coronavirus or catching the coronavirus. And similarly, very important, the hormonal manipulations that we frequently offer to breast cancer survivors, medicines like tamoxifen or the aromatase inhibitors, letrozole, anastrozole, exemestane, those are perfectly safe for women to continue taking during this viral pandemic. And we are encouraging all of our patients to continue those medications. They're very important medicines and should not pose any risk to you. Many women will have previously been treated with chemotherapy, some more recently or currently, others in the more remote past. We don't really think that there are lingering immune compromise problems for women who've had chemotherapy in the past, especially when you get 6 to 12 months beyond the chemotherapy window. Um, in the historic world, the world as we knew it 3 months ago, we did not see infectious problems arising with unusual frequency in women who had finished chemotherapy 6 months or more in the past. It's not like they are vulnerable to tuberculosis or measles or strep throat or any common infections. And so that doesn't immediately tell us that there's no greater risk for coronavirus in women like this. But I think it's a first order analysis that says most patients who are 6 months or more out from chemotherapy really should consider themselves reasonably intact from an immune point of view. And there is little reason to be unnecessarily worried that the fact that you had chemo a year ago, 2 years ago, 5 years ago, what have you, would affect your outcomes with respect to the coronavirus. So hopefully that's a reassuring message for the vast majority of breast cancer survivors who are thinking about this right now. Other patients have asked about the safety of ongoing treatments. And I know that Maya had sent me a list of questions ahead of time, and that was a very prominent one. So that's an area where the cancer centers are all trying to think through what makes sense. And I think what you're going to start hearing about if you talk to your friends or family members is that there's some things that seem really safe and we're going to encourage women to do that. There are other things that we're a little more concerned about for several reasons. And we'll speak about these separately. So the first thing to say that is really safe is the idea of deferring chemotherapy, deferring surgery um, for a few months. Many hospitals are trying to protect the operating rooms for several reasons. One is they are running short-staffed because they are rotating staff through so that people don't get sick. Secondly, many healthcare workers are already becoming sick and they have limited staffing at a hospital. And third, to be honest, if the hospitals are overwhelmed, a surgical OR, an operating room, is a space that can easily serve as an intensive care unit bed. They have all the facilities there for intubating people, running ventilators, and those kinds of very intensive therapies that someone might need. So many hospitals are trying to avoid surgery, and they have canceled all elective surgeries like hip repairs or plastic surgery or any elective type of surgery that would be necessary. For breast cancer patients, that means that many women who have smaller estrogen receptor positive breast cancers in particular, often found on mammograms, are being asked to defer surgery while they receive many months of hormone treatment. And I think that is an excellent and safe idea. There are very high levels of data that using upfront hormonal treatment for 6 or 12 months can be very effective at causing the tumor to shrink within the breast or the lymph nodes. We use it all the time to shrink the tumor and allow the patient to have lesser surgery. And in this current context of the pandemic, it's a very safe thing to do to defer the surgery for 3, 6, or even 12 months while the patient is receiving hormonal treatment. So that is something we're asking of our patients right now at Dana-Farber, Brigham and Women's, and our colleagues at Mass General here in Boston are doing the same. And I know that that is something happening around the country. I think that's a very safe thing to do, and patients should feel very comfortable pursuing that kind of approach. For women with triple negative or HER2 positive breast cancers, the discussions are a little more complicated because usually we think about giving chemotherapy to such patients. And the worry is, on the one hand, that we want to preserve the operating rooms, just like we were talking about. On the other hand, we know that chemotherapy can carry risks of low blood counts and potentially making people more vulnerable to infection. And of course, chemotherapy has side effects such that some patients will be needing emergency room visits or more visits to the clinic just to get their therapy. And again, the clinics, the outpatient clinics, are also running on a limited schedule. So those are more individualized discussions, but again, it's very safe to give neoadjuvant or upfront or primary treatment with drug therapy for many months in triple negative and HER2 positive breast cancers before surgery. And we do that all the time on a routine basis. And so I think women should generally be reassured, if they can get those treatments, that deferring the surgery is not of any long-term clinical consequences. Um, Other patients have asked about routine follow-up and mammograms and breast imaging and things like that. So one of the things that we have stopped doing at our cancer center and the cancer centers here in Boston and around the country, it's something actually that Susan Komen, the foundation, Susan G. Komen, has endorsed for patients, is to actually stop doing screening mammograms. That is to say, women who have no palpable lumps in the breast or no other concerning breast findings should not be going in for routine screening mammograms. And we are doing that again because the healthcare system is running very lean, and also because if you get a mammogram, then if you have a finding, then you need a biopsy and maybe even surgery, and we're trying to avoid that. American audience should know that around the world, most women are advised to get mammograms every 1 or 2 years. It's only in the United States that people push for once a year visits, and it's very safe to imagine deferring a mammogram for 6 or 12 months, especially at this time when you should be staying at home and when the healthcare system is stretched very thin. So that is our policy here in Boston. It's a policy that's been endorsed by the Susan G. Komen Foundation. It's a policy that's been endorsed by the Society of Breast Surgeons here in the States and by the NCCN, the National Comprehensive Cancer Network. So lots of expert guidance to suggest that it's very safe to defer routine breast imaging. And that also applies to women with a personal history of breast cancer who are just getting their annual imaging studies. It's very safe to defer those for 6 or 12 months. And hopefully by then life will be returning to normal and everyone can come on back in and get their mammograms and other breast imaging done. Now, just to point out, this is different than if you find a lump in the breast. If you find a lump in your breast, talk to your primary care doctor, talk to your imaging center. They will still be imaging women who find new problems or have health concerns about their breasts. But for asymptomatic patients who feel fine, nothing abnormal going on, either breast cancer survivors or the general population, very safe to defer mammography for right now. Similarly, for breast cancer survivors, we are deferring most of our routine check-in visits by 6 months or thereabouts. So many of you are in the habit of checking in with your medical team, surgeons, radiation oncologists, medical oncologists once a year. Um, you might even do it a couple times a year for the first 2 or 3 years. But if you're well and if you're feeling fine, there's really very little yield to any given visit. And so we are asking patients to defer those visits for, as we said, 6 months or longer to give the healthcare system the space it needs to adjust to this new COVID outbreak. Again, if you're having symptoms, if there's a problem, bring that to the attention of your team. But if your clinical team is saying, you know what, we need to reschedule you for the fall and you're feeling fine, that really is okay. So those are some very top line sort of remarks that I hope are generally reassuring for patients. I want to get a little more granular and speak to some of the other drugs we use, but Maya, you've got a question?
Yeah, just a
Please.
couple of follow-up before we go to the next section, and some actually we're getting live also through the stream. So maybe on this last part around postponing the appointments, we have a question that just came through, which is a person saying, I have a mammogram scheduled by my oncologist on April 21st. It is a 6-month check-in for her breast where she had breast cancer in 2018. Should she cancel it?
So, you know, if it's a totally routine thing, like they said, everything looks great, come back in 6 months, it probably is not essential. If the radiology report says, there's something here that we would like to repeat the imaging for, my guess is it could probably be delayed by a few months, but you might want to just ask your team how important it is to get that imaging. And to be honest, if they're even doing the imaging, many centers around the country are just not doing the work at this point. So your imaging date sounds like it's a couple weeks away. You might want to call the clinical office and say, you know, I'm aware of this issue. We were going to do it. Do you think it can be safely deferred? And they'll give you some advice based on the particulars of what the finding was 6 months ago.
Okay, great. 2 more questions just relative to what you just said also. Going back to just the risk with the personal breast cancer history, what if the person has had significant lymph node removal, sorry. Is that considered higher risk?
So the answer there is no. So the body has hundreds of lymph nodes throughout, and they are an important tissue for mounting immune responses. But when a woman undergoes lymph node dissection in the axilla, the armpit, they usually take out somewhere between 10 and 20 lymph nodes. And that has no impact on your long-term immune status or ability to fight off infections.
Okay, great. A couple of questions linked to chemo and targeted therapy. So the first is, actually, I was going to ask it based on what you said, which was very clearly, if people have had chemo at least 6 months ago, it sounded like, you know, they should consider themselves similar to, you know, just they're not immunocompromised, if I understand that correctly, right?
Right.
How about people that have completed their chemo treatment but are still in this, you know, up to 6 months window?
You know, again, the historic experience is that these women do very well and are not at greater risk for substantial viral infections, colds, you know, chickenpox, flu, what have you. But I think now, you know, is certainly a very appropriate time to practice good public health strategies, distancing, hand hygiene, cleanliness, all those things that can help. You know, it's not the time you want to have any kind of infection, because the last thing most people want to do right now is have to visit a clinic where there might be lots of people coughing or short of breath, or an emergency room which are packed with patients being evaluated for possible COVID infection. So I think it's just a really smart time to take care of yourself in that way, but I wouldn't be unduly concerned.
Okay, great. And maybe just, so now we have a number of questions around the theme of they're undergoing currently chemo and then whether they should stop. So, let me just kind of highlight a couple just to give it more tangible. So, a person is halfway through their chemo treatment and wondering whether they should complete Taxol treatment. Another person is on Perjeta and Herceptin and have another one in 3 weeks, and whether they should defer treatment in the context of metastatic breast cancer, and similar question on Herceptin. So both, the Taxol treatment, but also the targeted treatment, and, metastatic versus non-metastatic, if you could comment on those.
So for the Herceptin and Perjeta question, in theory, those drugs do not compromise your immune system. And so they should be safe to give. At the same time, they do require a trip to the clinic, which might, feel uncomfortable right now. So what we're telling our patients is that if they feel up to it, they can come into the clinic and get treated. We are very comfortable stretching out those visits. We usually give those drugs every 3 weeks, but if patients want to skip a cycle here and there, or stretch it out to 4 or 5 weeks, we're very happy to accommodate that preference. And I think for some women who have had years and years and years of Herceptin Perjeta in the metastatic setting, and have had very stable disease, it's certainly reasonable to take a short hiatus from that. And similarly, for patients in the adjuvant or early stage setting, where we typically recommend a year of these treatments, we are very open to the idea of shortening that by a few months, and I do not think that would pose any problem in the long term for patients. The value of the last few doses of Herceptin or Herceptin plus Perjeta to conclude a year of therapy is probably really, really small, if any. In fact, some studies in the past compared 12 versus 6 months of Herceptin, and there was hardly any difference at all, like a 1% difference. So those are excellent questions, and they are probably best directed to the individual team that's following the patient. But it is certainly the case that the drugs are safe, but because of the concerns over exposure and clinic visits, we are often slightly abbreviating treatment courses or stretching out those visits so that they're getting a little bit less frequent treatment.
Would that also apply to radiation therapy?
So radiation therapy, again, should not in and of itself pose any specific risk, though it does require going to the facility every day, which might feel uncomfortable. Many radiation doctors are beginning to use shorter courses of radiation, so-called hypofractionated radiation, which requires only 16 treatments instead of the historical 25 treatments. So that's one way to minimize some of the exposure. For certain patients who have very low risk breast cancer, they might use so-called accelerated partial breast irradiation, which is an even more abbreviated course and probably appropriate. The other thing to say is that for many women, the benefits of radiation are really small. So typically these are women who are 65 or 70 years or older. But we worry about our older patients because they seem to be more vulnerable to the coronavirus outbreak. And so for those women who have stage 1 ER positive cancers, they can often safely omit radiation therapy altogether without compromising their long-term survival. So there are a lot of these, unique and individual discussions happening in our clinics and around the world right now to give people the really important treatments, but to also look for areas where we can safely abbreviate or shorten the regimen without compromising on the patient's outcome.
And maybe one just last question that came in on that same theme. It may be too specific, but I'll just ask it the way it came in. The person asked, I had radiation pneumonitis and now have permanent lung scarring. Am I at high risk of complication if I get COVID-19? If I suspect I have COVID-19, when should I contact my doctor?
So if you suspect you have COVID-19, you should call your clinical team or your primary care doctor. Hospitals are developing specific triage lines for patients who have fever, cough, or other symptoms that might associate with COVID-19. They, in general, do not want you just showing up at the cancer center. They're very worried about infecting other patients. So it's better to call, assuming you're well enough, ahead of time, and ask what the correct protocol would be. Um, for other patients, the decisions are more complicated. So for patients who have metastatic cancer and who are getting therapy, for patients who are getting chemotherapy, the conversations are trickier because these patients are often getting very important treatments, and the treatments have more intensity. They do cause lower blood counts. They do cause more side effects. They probably do make people sicker. And in those cases, we are communicating a lot with our patients. We are, where appropriate, tweaking the doses or the supportive care regimens so that we think we're causing as little harm as possible while still giving effective therapy and trying to reduce problems like low blood counts and things. Your question about the radiation pneumonitis is an interesting one. The honest answer here is we have no idea. For most people who get even some radiologic evidence of pneumonitis or scarring, there are no real long-term problems. They're still able to sing in the church choir and train for marathons and do all the things that people like to do with their lungs. And I wouldn't have said it's a common problem. Whether that proves to be an issue if you get a pneumonia is something that we're all worried about a little bit, but we don't really have data to say one way or the other if it's a truly compelling concern.
Great, thank you. Yeah, let's continue, and we are getting more questions, but I'd want to give you a chance to continue along the theme you wanted to take.
Well, I think we've covered many of the issues in broad strokes about treatment, hormonal treatment, chemotherapy, radiation, surgery. We've talked a little bit about follow-up and mammogram imaging. I know that people have been asking, what should the healthcare teams be doing? And patients who go to different clinics may encounter different rules or guidance. To be honest, our own center, the rules change every day on what exactly the patient flow looks like and what kind of personal protective equipment the physicians and nurses and others are wearing. The issue here has been that there is a finite supply of masks and gloves and other protective equipment, and we are all doing everything we can to avoid consuming that unnecessarily. At our own hospital, the staff are wearing masks and using gloves wherever they can. These are usually not N95 masks, but just familiar surgical masks. And we are screening patients as they come in. If they have anything to suggest an upper respiratory infection or runny nose or cough or sore throat, they too are wearing masks. I suspect that these rules will change practice to practice based on the local environment, how prevalent the COVID virus is in your hometown, and the availability of medical supplies. So, that's the kind of thing that, you'll have to speak to your own medical team about. Many cancer centers are sort of reorganizing how patients sort of physically enter the clinic. This is true at many hospitals as well, with limited doorways for entrance and then screening right at the doorway to make sure that people aren't febrile, aren't having symptoms, those kinds of things.
Great. Just a couple of clarification, because I think at least one of the person listening here was not clear on how she should go about this. So her specific questions are, and I think you addressed it, but maybe being more specific around people that are currently undergoing chemo only with Taxol. So she's halfway through her chemo and wondering, and only on Taxol, and wondering if she should continue.
Yeah. So in general, for women who are in the middle of really important chemotherapy regimens, usually this is adjuvant or neoadjuvant chemotherapy with Taxol or AC or similar drugs. We do recommend that they try and conclude their course of therapy. So we're aiming to finish the standard treatments. That's having said that, we're also paying a lot of attention to how patients are feeling. We are more careful than usual. We're always very careful, but we're really trying to be careful to avoid excessive toxicity because we don't want patients to get dehydrated or be vomiting or end up with neutropenia and an irregular infection at this time. So, those are all things that when you speak to the clinical team, you want to discuss with them and raise as an issue. But wherever possible, we are trying to finish those standard courses of chemotherapy.
Okay.
In the metastatic setting, women with advanced breast cancer, it's a little trickier because those therapies can go on for a very long time. So whenever possible or appropriate, we are asking that they perhaps think about hormonal treatments if they haven't had those or haven't had them in a while, or that we are looking for oral chemo regimens such as capecitabine, or we are looking for ways to make the logistics work as easily as possible for the next few months without compromising on the patient's best treatment, so that hopefully the healthcare system will get through this and then life will return to more normalcy and people can resume more of the familiar schedules and drugs and regimens.
Great. And we've talked about Herceptin as one of the targeted drugs. Another questions we're getting is more on the CDK4/6. So Ibrance, if they're metastatic and they're on it, are there any complications to continue having these
So
treatments?
CDK4/6 inhibitors like Ibrance and Verzenio can cause low blood counts, and they can also cause other symptoms like diarrhea. So again, we're talking very closely with our patients and trying to figure out if it makes sense for them to continue the medicines based on how the experience has been so far. We're also asking them if they have had um, any problems with the medication. Again, I think common sense would say that if you're getting sick from these medicines, fatigue, um, low blood counts, significant diarrhea, I think it's worth reassessing whether you need to be on them right now. One could always reintroduce those in the months ahead. And it's a very individualized discussion because, you're talking to patients and it depends on what the other choices are. So if someone has, gotten a very long and substantial benefit from the Ibrance, maybe it's worth taking a hiatus. If someone clearly needs it still, then we're continuing on with those medications.
Great. Actually, we just got another specific question on a specific drug, whether Zelota is at a higher risk.
So Salona is a chemotherapy drug, and while it does not cause some of the side effects familiar to chemotherapy treatments, such as low blood counts as much or vomiting or things like that, it can have side effects. So again, I think the important thing is to say, how is that patient doing? Are they tolerating the dose? One of the things Zelota can cause is mucosal damage, mouth sores, diarrhea, rashes, and again, those are things, all of which in theory could, make you a little more vulnerable to being ill if you were to get an infection with COVID. So I think it's not that there's an absolute rule here, but with all these chemotherapy drugs, we're talking very one-on-one with patients to try and figure out, how are they doing? Are they really tolerating this as well as we want them to be right now? And if not, can we adjust the dosing? Can we adjust the schedule? Are there ways to make it a little more bearable for the patient so that we do all we can to reduce their potential complications?
Great. There's a couple of people that I think joined a bit later, so I'm going to make a statement that I believe is correct, which they're asking whether they're on tamoxifen or anastrozole, which are hormone therapy. My understanding from the earlier comment you've made that these are not considered as higher risk treatments, and people should not be worried about continuing being on them. Is that right, doctor?
That's absolutely correct. The hormonal manipulations, tamoxifen, the aromatase inhibitors, anastrozole, letrozole, exemestane, injectable anti-estrogens, fulvestrant, or the drugs we use to achieve ovarian suppression in some women, like Lupron, are all totally safe from an infection point of view. Now, it is true that Lupron and fulvestrant do require a physical injection, and that often means going to the clinic to get treated. So we are looking for ways to stretch out those visits. Lupron can be given safely once every 3 months instead of once a month. Faslodex really is a once a month drug, so it's a little trickier to find a solution for that. But the drugs themselves, the treatments themselves, pose absolutely no jeopardy to the patient in the way of a COVID infection.
Okay, great. We do have a number of people that have tuned in that are actually whether nurses or, pediatric therapists. So they're really kind of, their day job is really around patients. And so their question is whether, having had the history of breast cancer or currently dealing with breast cancer, whether they should essentially change anything, given that even without that history, in that context, people seems to be at higher risk.
Of course. Well, first of all, it gives us a chance to pause and just thank the remarkable work that all of the healthcare workers are doing. Nurses, clinic assistants, physical therapists, radiation therapists, physicians, all the folks who staff the hospitals. They have really stepped up around the world. And I know that I've never been more proud of my colleagues and the people we work with at the great hospitals and clinics in the United States. Um, for women who are on hormonal treatments alone or who finished their breast cancer treatments, we talked about this a little earlier, 6 or 12 months ago, I think there's very little reason to be concerned that there is undue or excess risk. There are the familiar risks of exposure, and that is something that clearly is an issue for healthcare workers and frontline personnel of every kind. But there's no excessive risk if you finished your therapy or if you are just on hormone treatment. For women who are on chemotherapy drugs, it is possible that there is greater risk. And I think there's also, greater vulnerability. The one thing we seem to be seeing as a consistent lesson is that the people who have the least the worst outcomes if they become infected tend to be older individuals, individuals with other health problems, particularly blood pressure, diabetes, hypertension. Um, Men seem to do less well than women. Obviously, older individuals seem to be doing less well than children. So, it's hard to know where to put chemotherapy in there, but I think that patients who have advanced cancer or people who are actively getting chemotherapy probably warrant extra precaution, and I would be doing what one could if you're actively getting treatment to reduce your exposure.
Great. I think you've covered this, but maybe this is just more close. So this person have had yesterday 25 rounds of radiation. And I know that radiation, we said, doesn't impact, but her question is, knowing that part of my lung received radiation, when would it be safe for me to return to work?
Yeah. So a fair
And
question.
and she's a labor and delivery RN. So
Oh,
it's in
wow.
that context. Yeah.
Well, another frontline healthcare
Yeah.
worker. Well, hopefully there's some babies and some good news to temper all the frightening news. Um, again, in general we think that radiation therapy is remarkably safe and that the impact on lung function is extraordinarily low. Um, I think that we're dealing with an unknown in terms of how a COVID exposure might affect that. Um, there are women who get radiation therapy and have hardly any lung field in the radiation field, and there are women who have substantial exposure to the lung because of the necessity of the radiation treatments based on their anatomy and their tumor stage. Um, again, here, I don't think there are any rules in place. I understand the concern. I think that for a labor and delivery nurse, I think the biggest risk is really just the routine exposure rather than anything that has to do with the radiation therapy per se.
Great. I have a question, and we can follow up on this, the person who asked the question, because it's a very long question, but I'll actually summarize it. It's really a person that have been diagnosed with a recently diagnosed with a very rare breast cancer. She's in the New York State area, and essentially she's wondering, in this context, how does she find a cancer facility that can help her with her diagnosis? Maybe, can you speak about, are there like second opinion around telehealth or things that, especially those people, whether they have immediate access in their location or whether they have rare forms of breast cancer and are in the normal routine would go somewhere else, how can they access that in this context?
Sure. Well, of course, New York is at the moment the epicenter of the American COVID pandemic, and so I'm sure that healthcare systems are really strained there. And there are obviously wonderful cancer clinics throughout New York State and New York City, and I assume she has routine access to some of them from her past history. Um, it's probably never been easier to get a virtual second opinion. As many of the audience may know, Medicare changed all the rules about 10 days ago that historically have meant that to get a second opinion, you have to go to the cancer center and be physically seen. So we are scheduling virtual second opinions at Dana-Farber. And I know that major cancer centers around the country have gone to these kinds of virtual second opinions. You essentially register the way you would as a routine patient, but they set up a virtual teleconference, usually over Zoom, like we're doing today. And I think that those can be very helpful for many people around the country if they have unusual cancers or specific questions or want a second opinion on what needs to be done during the pandemic. Again, I know that many major cancer centers are very willing to offer this consultation service through usual insurance or Medicare coverage. This is something we were never doing 2 weeks ago, and now we're doing it all day long. So it's a brave new world of telehealth and telemedicine.
So just so I better understand, and maybe for our audience, so if a person is listening and want to get a second opinion, just let's take Dana-Farber, do they go to your website? How do they kind of get, to really connect for a second opinion?
Sure, I want to make sure this doesn't sound like an ad for
No, no, but I'm
Dana-Farber, though
just
of course
curious.
we're
I mean, it
happy
could
to
be
see
the
you.
same, but
Yeah,
yeah,
but yes,
and
if
it's
you go
not.
to
But I want to
the,
be no, I actually no, but it's not. But I just want to be help our
oh, we're
people
happy
here
for
so
the
that they have that
we're
option.
happy for the plug, and we have a fantastic group of new patient coordinators. So you would go to our website, danafarber.org, or whatever cancer center website you regularly see or would like an opinion at. You would go to, usually they have it by disease program. They have a breast program, a GI program, a lung program, all those things, and you usually will find a phone number for a so-called new patient referral or an intake number. And that's the way we've always scheduled patients. But if you call them now and you say, I'd like to set up a virtual consultation or a telemedicine consultation, I think people will be very open to the idea of helping you both at our center and at major cancer centers around the country.
Okay, great. I do have a couple questions, but first, I mean, did you want to comment on other aspects, or should I just go through the couple of questions?
Why don't you move on to the other questions?
Yeah, so a couple of questions. Some of them we may have covered. I mean, we did cover, but I think people are just more specific around. One, should they avoid, this is more just kind of, best practice. Should they avoid grocery stores, given that, I know that some grocery stores, like here in Massachusetts, we're starting to see social distancing, but obviously not every grocery store is set up that way. So is that a place where people just should avoid them if they can?
Yeah, well, there's clearly community transmission happening, and that is how the virus is being spread at this point in the United States and in many other countries around the world. So I think for breast cancer survivors, breast cancer patients, families of breast cancer patients and survivors, really it's a matter of following the usual common sense rules that are being put in place. Again, practicing appropriate social distancing, minimizing exposure, using good hand hygiene, and taking care of yourselves in those ways. There's nothing really unique about the risk there for breast cancer patients for the most part. And so I would just follow what the evolving public health advice is in your geography.
Great. We have a person, I mean, we've covered this, but just being specific about treatments. So currently receiving carboplatin and Taxotere. I mean, that would fall under the chemo treatments,
Right.
right? Yeah. So essentially the answer is they would be at higher risk, correct?
I think that probably is true, but again, there's no science on this as yet. It's just kind of common sense. That is a regimen that we often give with a lot of corticosteroids like dexamethasone, which might, again, make one somewhat immunosuppressed. So I would talk to the team about, just making sure that this is an essential treatment right now. These are very well studied and widely used drugs and are very important for many women. But at the same time, it may be worth asking your team, are we sure we're doing the right thing? Are there ways to make this even safer than it might be otherwise? How should we think about it?
Great. a question around just the immune system overall. Maybe, just for the audience to understand after cancer treatment, anything that actually it's a long kind of question. So I think people are asking whether, just how the immune system evolved after cancer treatment, but actually separately from that, also people are wondering whether, especially those that have postponed surgery or treatment, anything they could do today, other than, obviously if they're on hormone therapy, etc., that could, either improve their, kind of their situation, or, that any advice.
Sure.
Mhm.
So there's no specific thing that boosts the immune system. For cancer patients getting chemotherapy, we use growth factors to keep the white blood cell higher. But for the general public or people who are not getting chemo, there's no supplement or drug or thing that boosts the immune system. And the good news is that most cancer survivors and most women actively getting treated with chemotherapy or other drugs still have a pretty robust immune system. So we don't usually see immunocompromised infections or atypical pneumonias or funny fevers or things in the vast majority of patients with breast cancer. I think some real common sense stuff here is a good idea. So people should be eating good food, a well-balanced diet, making sure they're getting plenty of fresh fruit and vegetables, making sure that if they are getting plenty of protein. It's good to get activity. So everybody should, if they can, get some activity every day. If you have the chance to walk outside appropriately using social distancing, that's great. If you have a gym in your home, that's great. If you don't, just walk up and down the stairs many times. Do push-ups. You can do all sorts of things to try and keep yourself physically fit. And I think that's really important, especially now. If you have other health problems, diabetes, high blood pressure, other cardiac problems, lung health problems, now's a really good time to optimize the treatment for those. Again, we're all learning about COVID sort of day by day, but it does look like people who have other major health problems seem not to do as well if they get infected. And so taking as good a general care of yourself with nutrition and activity, and taking the appropriate treatments for your known existing other health problems, really important at this time for breast cancer medicines and therapies.
Great. And maybe just the last kind of questions. I know we need to wrap up in a few minutes, but we have a number of people that, whether they're survivors and on maintenance treatment, or maybe closer to when they've had treatment or undergoing treatment, who are spouses of healthcare providers, which are, working in high volume ICUs, dealing with COVID plus patients, the spouses. So the question to you is, beyond them following local suggestions about staying at home, should they be distancing themselves within their home and sleeping in separate rooms?
So there's been a lot of stories, for instance, on social media and Twitter and places like that about frontline healthcare workers and the choices they are making to self-isolate, um, particularly ICU, emergency room, people who are coming in intensive contact with patients who are likely to be infected with COVID. Um, I think every family has to make a choice like that on its own. There really is no reason to think that the breast cancer community is at greater jeopardy than the average public when it comes to contracting the infection from spouses or partners who might work in healthcare. So I know that even amongst my colleagues in Boston and around the country, there are different approaches that people are using, and I don't think anybody has science to say what's right and what's not. I would trust your instincts and sort of pay attention to what seems like good advice, but there are no hard rules here.
Great. Maybe, Doctor, thank you so much. Maybe as we conclude, because I see a couple of questions coming up that I think we've addressed early, at the very beginning, around, whether they're, due to start radiation, they have femara due to other medical conditions, and whether they should be worried about delaying radiation. Maybe for those people, just to summarize as we conclude, that, need to go through surgery or radiation or treatment,
Yeah.
If we can conclude on that theme,
Yeah.
just so that everybody that's tuned in a few
Sure.
minutes late can hear it from you.
Absolutely. Well, let's try and hit some of the highlights then.
Yeah.
The first is that, for women who are asymptomatic or doing well, either breast cancer survivors or the general public, it's very safe to defer screening mammography for 6 or 12 months. I wouldn't be worried about that. Um, Secondly, for women who are on hormonal therapies, tamoxifen, aromatase inhibitors, all those kinds of very important medicines ought to be totally safe through the COVID pandemic, and I would continue your regular medications. Third, routine visits are often being suspended or deferred by clinics, and I think that's quite reasonable. If you have a concern, speak to the team, but if you're feeling fine, the routine check-in doesn't really accomplish all that much, and so I would feel very comfortable deferring that by a few months. The trickier questions are for women who are newly diagnosed or who are in the middle of a complicated multidisciplinary treatment program involving surgery, hormonal treatments, chemotherapy, radiation therapy, all those kinds of things. Um, we are in many instances deferring surgery, especially when there are good other drug options that are very safe. So for women who have hormone receptor positive or estrogen receptor positive breast cancers, we are often giving anti-estrogen hormonal therapies like tamoxifen or aromatase inhibitors for many months to allow us to defer the surgery. That's a perfectly safe thing to do. We have a large, vast literature supporting that as both effective and safe for patients. For women who have HER2 positive or triple negative breast cancer, it's a little more difficult to discussion because the chemotherapy is part of the traditional program there, and it can be logistically hard to figure out which is going to be safer right now, surgery or chemotherapy up front, and you should talk to the team about what approach they think is right for your given case. Um, in terms of the sequencing of radiation therapy, nobody loves the idea of delaying treatment, but delaying radiation by a couple of months, or conversely giving radiation first and then giving chemotherapy afterwards, those are all strategies that are probably quite safe for the vast majority of patients. And again, the details matter a lot, so you'll need to talk individually to your treating team, but in many instances, we are able to sort of rejigger the schedule so that we think we're preserving healthcare resources while still giving very effective therapy to our patients. Um, so, as I said, the other thing I don't want people to lose track of here is the good general public health stuff, social distancing, hand hygiene, taking care of yourself physically, emotionally, and nourishment, activity, making sure you're addressing all your other health problems as effectively as you can. I think those are probably as important as anything else in the grand scheme of things for breast cancer patients and their families at this time.
Great. Well, so first of all, I want to thank you, Dr. Burstein, for spending this hour with us. I think it's very
A
helpful
pleasure.
for us and our audience. I want to also thank everyone that has tuned in here. We're here for you. We'll be doing more of these webinars throughout the month. And also for those of you, we will be posting a recording of this session to our Facebook page and to our website. So if you want to either share it after or come back to it, it will also be available. So with that, I just want to thank you very much, Doctor. Thank everyone for tuning in, and stay safe, and hopefully we'll continue this discussion.
Absolutely. So final words, as you said, stay healthy, look out for each other, keep in close communication with the healthcare teams. Even if people are working virtually, they're spending all day on the phone, on Zoom, on things like that, connecting with patients, and it's a great time to take advantage of those resources. Have a great day.
Great, thank you. Everyone have a great day. Thank you for tuning in.